All right, good afternoon, everybody, and thank you for joining today's webinar. Welcome. And so today's webinar will be focused on core community psychiatric support and treatment service, again, or CPST, and it's in particular to the implementation of core, and this is a service-specific training series. My name is Boris Vilgorin, and I'm with MICTAC, or Managed Care Technical Assistance, and I'm joined by my colleagues Tara and Meg, and also we have our state partners who will introduce themselves both from OMH and OASAS to do today's presentation. Before we jump right into the presentation, as always, some basic logistics to go through. So again, as with a lot of our presentations, today's presentation is being recorded, and both the recording and the slides will be made available. We are doing a number of these service-specific trainings this week, and so our goal is to release and make all of the recordings and slides available after we complete all of these recordings. So stay tuned for that, hopefully by the end of the week, but it might be also next week, but definitely we'll be making all of this available. As always, I also encourage folks to chat in the questions throughout the presentation. We do have time at the end put aside to answer as many questions as possible. We are going to be focusing predominantly on the service at hand and the service of today's presentation on community psychiatric support and treatment. Again, we want to make sure we give the opportunity and time to really focus on today's service and really have the opportunity to answer questions that folks might have, and also for our state partners opportunity to present. If you do have other questions around core, kind of general implementation questions, designation questions, and so forth, there are a number of resources already available. I know OMH has a particular page dedicated to core with a lot of those resources over there, so definitely encourage folks to visit that. We at MICTAC, as we have these recordings available, we post them on our website, and there have been a number of webinars already done by our state partners that we have posted on our website, especially around kind of these general information around core. So we strongly encourage folks to visit those, listen to those recordings, view those slides as well. So again, just wanted to remind folks that today's presentation is a service-specific training, and today we'll be focusing on CPST. And so with that, again, please chat in the questions as they come to you, and we'll try to answer as many of them as possible at the end. And so without any further ado, I will turn this over to our state partners to start the presentation.
Thanks, Boris. This is Katie Merrill. I'm the Director of Rehabilitation Services here at the Office of Mental Health, and I'm joined by a couple members from the Rehab Services Unit, Amanda Polmain and Stephanie Rodriguez. We also have Danielle Olson from OASAS and Nicole Haggerty, also from OMH, here to help us with questions at the end of the presentation. As Boris mentioned, today we're going to talk about community psychiatric support and treatment. We're going to introduce the updated service definition and components from the operations manual. We're going to talk briefly about staff and supervisory qualifications and highlight some of the key programmatic changes from BH HCBS to core as it pertains to the CPST service. Next slide. So why are we making these changes? As we transition from BH HCBS to core services, we've really had the opportunity to incorporate a lot of lessons learned and feedback from providers. Over the last 5+ years, we've gone out and done oversight and monitoring visits. We've provided extensive technical assistance, and we've met with many providers to hear about what's working and not working. And we wanted to incorporate as much of that as we could into the new program design. So when you read the operations manual, we hope that you see a lot of your feedback in there and that you see some improvements that will lead to higher quality services. We made some changes to the language that will hopefully show through the service definitions and components what this service looks like on the ground. We wanted to be more descriptive in what the interventions look like and give staff language that they can use in their documentation to help illustrate the good work that they're doing in progress notes or in service plans. And lastly, we wanted to promote role clarity. We know that HARP members have a lot of services and staff in their lives. They may have case managers and health home care coordinators, recovery coordinators. They may have primary care. And it gets confusing who's doing what. And so we wanted to make sure that we are completely clear around what core services are, and if you're a CPST clinician, what your role is in that person's recovery. Next slide. So I'm going to briefly go over some of the key changes from BH HCBS to CORE as it relates to CPST, but then I'm going to turn it over to Stephanie and Amanda, who will walk through some of the details. So as far as the definition and components go, really what we're looking at is a mobile clinical treatment service with some allowances for intensive rehabilitation counseling where appropriate. We took the time-limited wording out of the definition, and that's because we wanted to make it clear that the duration of CPST should really be person-centered and based on the individual's needs and preferences. We reorganized the components to create some distinct categories and call attention to specific interventions. For example, the first component is now person-centered planning, and that allows for billable interventions including recovery planning, collaborative documentation that's done with the individual, and communication and collaboration with collaterals, including outside service providers. So the time that staff spend talking to an individual's family of choice, or perhaps a housing provider or a care manager, that could be billable time if the individual has identified those service providers or family members as collateral, people who are important to them in their recovery. We offered clarification around the intensive rehab counseling component. So as you're reading through the operations manual, it's hopefully a little bit more clear when you might use psychosocial rehabilitation for ongoing rehab needs, and perhaps the intensive rehab counseling component if there's an emergent need or someone who's very highly motivated and would benefit from receiving that service from a professional or licensed staff. We also have some additional optional components that are based on provider qualifications. So if a CPST provider has nursing or prescriber staff available, then they could offer health monitoring and medication treatment or medication management. That's something that we see a lot of value in. We know that many people prefer to get their medications and counseling through the same provider when possible, and so we would love to see more CPST providers who are bringing in those qualified medical staff. But we also know that with workforce shortages, that's not really an option for all agencies. So we made those optional components that are going to be based on staffing and capacity at the provider. Next slide. Some changes in access to core services will promote upfront engagement of the individual. So rather than needing to go through an eligibility assessment and needing a referral through the care manager or through a recovery coordinator, we would love to see CPST clinicians and others engaging individuals in core services right up front. We think that this is going to promote access and make it much easier for HARP members and HARP-eligible HIV SNP members to access this benefit. There are clarifications in the manual around staff qualifications. So CPST is really important to pay attention to the scope of practice and who's delivering which interventions based on their training, qualifications, and credentials. There is an allowance for some limited on-site services with CPST. You do need to have a documented clinical rationale, and it needs to be based on person-centered needs. Largely, this service will remain off-site in home and community-based locations as a mobile treatment service. We've removed the annual hours cap and daily unit limits so that person-centered planning can really drive the intensity and utilization of these services. And we put in place recommended unit ranges that are intended to illustrate the scope of services. So we're recommending CPST to be anywhere from 15 minutes to 90 minutes, and that's based on the individual's need. And if you need to exceed that, that's okay, but you do need to document medical necessity. So there's going to be a little bit extra that we're going to look for in the chart in those circumstances. These are just a brief overview of the changes, and now we're going to dive into some of the details with Stephanie. Next slide. Right. Thank you, Katie. My name is Stephanie Rodriguez from the Office of Mental Health, and I'll be taking you through CPST's definition and components. Next slide, please. So Community Psychiatric Support and Treatment, or CPST, includes goal-directed support and solution-focused interventions with the intent to achieve person-centered goals and objectives. This is a multi-component service that consists of therapeutic interventions such as clinical counseling and therapy, which assists the person in achieving stability and functional improvement. CPST addresses behavioral health barriers that impact daily living, finances, housing, education, employment, personal recovery and/or resilience, family and interpersonal relationships, and community participation. Next slide, please. CPST is designed to provide mobile treatment services to people who are having difficulty engaging in site-based programs or have not been previously engaged in services, including those who had only partially benefited from traditional treatment. CPST allows for delivery of services within a variety of permissible off-site settings, including, but not limited to, community locations where the individual lives, works, learns, and/or socializes. Next slide, please. So there are 7 CPST components, 2 of which are optional components based on staff qualifications. I'll read through these quickly and we'll go into more detail in the next slide. The first component is person-centered assessment, service planning, documentation, and collaboration, individual and family psychotherapy and counseling, integrated co-occurring disorder treatment, crisis prevention, intensive rehabilitation counseling, health monitoring, and medication treatment. Next slide, please. So the first component we're going to go over is person-centered assessment, service planning, documentation, and collaboration. This component is used to elicit a person's recovery goal, establish objectives, and plan treatment services and interventions. It's also meant to regularly monitor progress towards their goals and objectives, and it includes collaboration with family or natural supports and other service providers. This component also includes updates to the ISP as needed. Next slide, please. Individual and family psychotherapy and counseling. So this is a clinical counseling or therapy with the person and/or their family, or natural supports as identified by the person, and this of course includes family of choice. It focuses on the person's goal in recovery, addresses any targeted symptoms, and supports community participation. Next slide, please. Integrated co-occurring disorder treatment. Integrated evidence-based model for co-occurring SUD and SMI, and this can also be used for tobacco use disorder treatment. Staff can utilize motivational interviewing and stage-wise interventions, as well as cognitive behavioral and harm reduction techniques. As always, when delivering integrated treatment, communication and collaboration with other service providers is critical. Next slide, please. Crisis prevention. This is a component meant to prevent crises, reduce risk of repeated crises, This includes assisting the person in any of the natural supports they identify a potential psychiatric or personal crisis, and develop a crisis management plan as appropriate. Next slide, please. Okay, intensive rehabilitation counseling. So this component utilizes customized interventions to support rehabilitation goals. It's designed to intensely assist a person in attaining and sustaining meaningful life growth. They may have contemplating a rehabilitation goal at this time or made a commitment to achieving that goal. The practitioner should also provide targeted intensive interventions necessary to address any immediate risks. The practitioner can also help the person with independent living skills, ID and engagement of support services, and restoration of functioning. Next slide, please. So this is our first optional component. So health monitoring is used for measuring of health indicators. These can be things such as checking lab work or taking vitals. So this component must be delivered by qualified staff, so someone such as an RN or a physician, but we'll go into the details of this later. Next slide. Medication treatment management. This is also an optional component.
Medication treatment management can also be used for monitoring and evaluating symptom response, writing prescriptions, medication and education, and this may include medication-assisted treatment, or MAT, and nicotine replacement therapy, or NRT. This must be delivered by qualified staff, such as a psychiatrist, but again, we'll go into more details about the qualified staff in the upcoming slides. Next slide, please. So now that we've gone over all 7 components of CPST, let's go over some examples of what core CPST could be used for. It could be used for engaging a person in solution-focused therapy sessions, providing evidence-based family psychoeducation, using motivational interviewing to create and resolve ambivalence regarding change, and patient education and medication-assisted treatment by a qualified prescriber. Next slide, please. And now I'll be passing it over to Amanda Pulmain, who's going to take you through qualifications and trainings for CPST.
Thank you, Stephanie. My name is Amanda Pulmain from the Office of Mental Health, and next we will be reviewing the necessary qualifications and training requirements to provide community psychiatric support and treatment through CORE. CPST may be delivered by a licensed or credentialed staff within their scope of practice. As you can see from the chart, we have the components broken down individually on the left, and the qualified staff who may deliver these components on the right. Under CPST, it is important for both staff and supervisors to continue to be aware and keep an eye on which staff can provide these services to be sure they can continue to provide services within their scope of practice. For example, health monitoring services can only be provided by medical staff, whereas the clinical counseling and therapy components can only be provided by licensed therapists. Next slide. The use of student interns. Student interns may also deliver components appropriate to their educational program. They must be participating in a supervised educational program at an institution approved by the State Education Department, leading to a degree and eligibility for licensure certification in an allowable profession. Next slide. Supervision is critical to the success and quality of services when delivering CPST. Clinical supervision includes case consultation, risk management, and balancing caseloads for staff. The clinical supervision for CPST should be appropriate to the licensure and scope of practice of the practitioner. More information around licensure and scope of practice is available through the Education Department's Office of the Professions. The link is provided in the slides, which you will be receiving at the end of all the service-specific training webinars. Agencies may also choose to use a split supervision model, where an administrative or task supervision may be provided by unlicensed staff, including peers, providing a career ladder. This split model of administrative task supervision may only be provided in addition to clinical supervision and not in place of it. Next slide. Training and workforce development are critical to the success of CORE services. All CORE CPST staff and supervisors are required to complete modules in psychosocial rehabilitation, person-centered planning, motivational interviewing, shared decision-making, trauma-informed approach, and wellness self-management. These webinars consist of modules that provide foundational knowledge and skills necessary to develop essential competencies for the delivery of CORE services. These are contained in the Center of Practice Innovation's Learning Management System. Next slide. An additional requirement training for CPST staff and supervisors is the application of CORE principles, CORE CPST. This additional required training is also hosted in the Center for Practice Innovation's Learning Community, an online learning management system. The timeframe for completion of all the above-mentioned trainings are outlined in the staff training memo, which is currently in final approval, preparing to be published shortly. Next slide. Next, we will be discussing service delivery for CORE CPST. Next slide. Services are delivered with respect to the individual's preference regarding days, times, modalities, and locations that are convenient for them and best suited for their desired outcomes. CPST is intended to be delivered off-site only. See Operations Manual for details on the expectations. The Operations Manual can be found on the OMH course-specific website. This link was also provided in the chat box at the start of this presentation. CPST is offered one-to-one only, meaning one clinician to one individual served. CPST may be delivered via telehealth, telepractice when clinically appropriate. Next slide. Intensity and recommended unit ranges. The scope of intensity of core services should be based on the level of support needed to support the individual in achieving their recovery goal and sustaining recovery. Recommended unit ranges have been developed to illustrate the scope of service and program design. Next slide. The recommended unit range for CPST is 1 to 6 units that are 15 minutes in length for a total of 15 to 90 minutes. Next slide. ISPs should be developed utilizing these recommended ranges and do not apply to an individual in crisis, although the crisis should be clearly documented in the progress note. The unit ranges may be exceeded when a short-term increase in intensity supports the goal acquisition. Outside of crisis situations, the decision to exceed the recommended range should only be made in consultation with the clinical supervisor. Next slide. To promote role clarity, CPST is not case management, personal care services, or a replacement for custodial care in an institutional setting. CPST is a mobile treatment service intended to support individuals with achieving stability and functional improvement. I will now be handing this back over to Katie, who will be continuing with the summary and case examples.
Thanks, Amanda. Next slide. So I'd like to share a case example of an individual who would benefit from CPST. So we have Jason, who's a 42-year-old man who lives with his mother and stepfather in the rural North Country. He enjoys hunting, fishing, and hiking, and occasionally picks up landscaping gigs during the summer and spring. He's struggled to maintain full-time employment. He is diagnosed with bipolar II and alcohol use disorder. Jason has not been regularly engaged in therapy or treatment since he graduated from high school, so it's been well over 20 years. He says transportation barriers and self-stigma have gotten in the way of his keeping clinic appointments. His parents have made several calls to mobile crisis due to a recent increase in substance use. So on next slide, we can talk about how CPST can help Jason. A mobile crisis team made a referral directly to the CPST provider, and Jason is now receiving counseling to treat co-occurring disorders. His mental health counselor engages him through motivational interviewing and dialectical behavioral therapy. And with the support of his counselor, Jason is empowered to talk to his primary care physician about naltrexone to reduce his alcohol use. He also works on building new distress tolerance skills, which help reduce his urge to drink and have improved his relationship with his family. And he started talking about looking for regular part-time employment, something more than the landscaping gig. So with the support of his counselor, he engaged in some intensive rehab counseling to really refine that goal. And his CPST clinician then connected him with a PSR provider to provide the ongoing psychosocial rehabilitation that will support that work-related goal. Next slide. I want to highlight some of the reasons why CPST worked for Jason in this case example. Number one, the mobile treatment aspect of it reduced the transportation barriers and the stigma concerns associated with seeking help. So Jason was able to be engaged in home and community-based settings, which made it easier for him to access the services. The provider was able to offer integrated counseling for co-occurring disorders, which meant that he didn't need to access a siloed system of care, but instead he could receive counseling for both the alcohol use disorder and bipolar through the same counselor who was trained to treat both disorders. By offering a focus on building distress tolerance skills, the mental health counselor was able to help prevent crises and gave him the skills needed to manage his cravings and urges. And then with coordination and collaboration with the primary care provider and making that referral over to the psychosocial rehabilitation provider, the CPST clinician was able to really use that person-centered planning component to the fullest. They were able to ensure that integrated care and the seamless warm handoff to the PSR provider to work on that work-related goal. All right, last slide. I'm just going to wrap us up today with a few highlights and things that I want you to take away from today's training around psychiatric support and treatment. First of all, CPST consists of person-centered clinical and rehabilitative services that are provided by licensed and qualified staff in community-based locations. So we're talking primarily off-site. We're not going to be in a private practitioner's office or anything like that. These services are mobile treatment and rehab services, and that is really one of your big takeaways. That's what makes us different from clinic or from many other site-based programs. You heard us talk about evidence-based practice throughout this training. We called out specific ones like cognitive behavioral therapy, integrated treatment for co-occurring disorders. We talked a little bit about DBT in the case example. So whenever you're providing community psychiatric support and treatment, we want those clinicians to be incorporating as much evidence-based practice as they can into that work. We're supporting that by offering trainings through the Center for Practice Innovation. So the essential trainings will call out some of those EBPs, and certainly there are a lot of continuing education training opportunities available through CPI as well. CPST promotes the inclusion of family of choice and other collaterals or people who are identified as important to the individual. And because of this, we're able to promote integration, coordination, and the involvement of natural supports, which we see as so important for addressing the social determinants of health for our HEART members. And lastly, we do have those optional components that are included that allow for psychiatric services if a provider has appropriate staff. So we have medication management and health monitoring, and whenever a CPST provider has a prescriber and nursing staff available, they're able to offer those components, which will really ensure comprehensive clinical care for individuals receiving CPST. I believe that that's everything we wanted to cover today. If we go to the next slide, we would be happy to answer questions. As I mentioned earlier, I'm joined in the room by Amanda and Stephanie, but we also have Nicole Haggerty and Danielle Olson on the line to help with questions.
Excellent. Thank you, Katie and the team, for a great presentation. We are now going to turn to our Q&A section, but before we do, first, thank you for folks who already submitted questions, and I would encourage others to continue submitting the question around CPST. Again, just a quick reminder, we are recording and we'll be making both the recording and the slides available after we complete the series on all the service-specific trainings. So with that, let's jump right into some of the questions we have received, and hopefully there's others that I think are coming as well. So one of the questions that we got is, can this service be provided via phone or video?
So as of right now, with the COVID-19 pandemic, we're working under certain waivers that allow us to provide services via telehealth, and that's true on the OMH and on the OASAS side. So as of right now, CPST under BH HCBS can be provided via telehealth. We believe that as we move forward with core services, there will still be some allowances for CPST to be provided via telehealth. We're still working on what exactly that will look like long term. The rates are really designed to support community-based service provision. So what kind of standards we put in place around telehealth moving forward will be defined in guidance forthcoming.
Excellent, thank you. The next question is about the qualifications for individuals for this service. So I think it was mentioned that a licensed individual can provide the service. I guess the question is, can a master's in clinical mental health counseling provide CPST, or do they need to be a licensed clinical mental health counselor?
So you don't need to be an LMHC, but you would need the limited permit if you have that master's degree. So limited permit in mental health counseling would be appropriate.
Got it. Thank you for that. Next question, talked about some of the limitations or proposed or suggested timelines. We have a question on how long should a client receive CPST service?
So the duration for CPST is going to be completely person-centered. We would like to see the CPST provider working with the individual to determine what's appropriate to meet their goals. Over time, there may be a role for the health home care manager and MCO to also play a part in that conversation and whether or not the service is still appropriate for the person, whether they could have their needs met at a different level of care. But we, as the state, are not going to put a policy out around a recommended duration. That's really a person-centered decision to be made.
Excellent. Thank you. There's a question specifically to the case study, but a general question as well. So I guess, and maybe this is a clarification, Katie, when you were going through the case study, you weren't implying, or maybe you were, that the CPST provider were handing off the case to PSR, because the question is, can both be provided, at the same time? Well, not during the same, actual time, but, can a person receive both CPST and PSR?
Yeah, absolutely. You could receive CPST and PSR. So the case example is just meant to illustrate how the services could be used for one individual. And in that example, what we were envisioning is an individual identifies a work goal, and the use of intensive psych rehab counseling is appropriate to help refine that goal and help determine what exactly this person is going to need in order to be successful with that goal. And then once they determine that psychosocial rehabilitation is appropriate, they can make that referral. Because it's something that could be done by a lower level staff. You don't need a licensed staff at that point. So for Jason's case example, the CPST practitioner would continue to work with him, providing the DBT and the skills training that they were doing on the clinical side. And in this case example, they referred out for the rehab side of things. But absolutely, individuals can receive PSR and CPST. You don't have to transition from one to the other.
Excellent. Thank you. There was a question as we talk about multiple services about CPST and clinics, especially if somebody is transitioning from CPST to clinic. I guess that's one of the options that could happen. Are there anything that providers should be thinking about in those instances, or anything in general as it relates to CPST?
Sure. So we actually made some changes around the CPST and clinic co-enrollment issues that we had under adult BH HCBS. So when CORE is implemented, really encourage you to read the benefit and billing guidance, including the footnotes for the exact details on this. But what we have been able to allow is that if someone wanted to go to an outpatient clinic for med management only, then they could continue to receive their mobile therapy through CPST. However, you couldn't get therapy through the clinic and through CPST at the same time. That would be a duplication of services. But in the event that a CPST provider just doesn't have a prescriber on staff and the individual needs psychiatric prescribing, they could go to a clinic for that service. We also have an allowance for people to engage in pre-admission at the clinic if they're ready to transition. They've received that maximum benefit from CPST and they're ready to continue their clinical counseling and therapy at an outpatient clinic. You could do the pre-admission visits while they're still in CPST to allow for a warm handoff.
Thank you. So in a similar vein, there's a follow-up question around health monitoring, right? So one is just confirming that health monitoring will also need to be done at home through CPST, but also there's a part two of the question is, could that be provided in a clinic if a clinic offers that service while somebody's getting therapy through CPST?
Sure. Yep. Someone could receive the health monitoring service as long as the CPST provider isn't also providing it.
Got it. All right. Thank you. And the server, but if they are going to provide it, it should be in somebody's home, correct?
Yes.
Health monitoring.
Right.
Okay.
These are off-site services.
Excellent. I also just want to point out there's a number of links that all the way in the beginning of the presentation, I know Katie, I think you included, and I know Tara just included as well, to the core benefit and billing guide. So some of those things that I've mentioned, and I know Katie mentioned, please feel free to take advantage of those links that have been posted in the chat box as well. So just looking at other questions, and again, Katie and others, feel free to jump in to any other questions that have come in or anything else that you want to address while I look for other questions.
Sure. I'm seeing a couple of related questions around the intake piece. So one question is, I'm wondering what the intake process looks like for core, and then another around the referral. So I mentioned that we no longer have the eligibility assessment. And there's a question of, do you still need the initial plan of care? So I'll try to answer those together. Number one, you do not need a health home plan of care in order to provide core services. So there's that piece taken care of right up front. Core are going to be driven by the individual service plan, or ISP. And so in the case of CPST, you're going to have that practitioner meet with the person, engage them through intake and evaluation using person-centered planning approaches, and they will develop an individualized service plan specific to CPST with that client. What the actual intake process itself looks like is going to be largely driven by the provider. So you have a little bit of room to determine if you want to use specific screening tools or if there's an intake form that you like to use. But if you read the operations manual and the benefit and billing guidance, you'll see just a couple of required pieces. Things like you must notify the MCO within 3 business days of initiating services. So I would just direct you to the operations manual and the benefit and billing guidance. And then if you have additional questions about intake and evaluation after reading those, please reach out to our mailbox.
Excellent, thank you. Okay, let me see what else we have. So there's a question, I guess, about homeless individuals in CPST. Again, I think the expectation is to be out in the field and work with individuals. I don't know if there's any suggestions or thoughts about that.
Yeah, so if someone is homeless, whether they are sheltered or unsheltered, I think that the person-centered planning process is the perfect opportunity to talk to them about when and where they want to receive services that they feel is safe and appropriate. If someone is appropriate for CPST, this is the level of service that they would like to receive, then you could talk to them about receiving services in the shelter, in a community location, and in very rare circumstances, you may be able to provide them on site. I strongly encourage you to read the operations manual to see what that documentation looks like to justify that. It is intended to be short-term, because really, if someone is able to attend site-based appointments on a regular basis, then we think that they may be more appropriate for an outpatient clinic rather than this level of service. So if you have an individual who's homeless, I would just engage them in that conversation and make sure that you're talking to them about their preferences for where they want to receive those services.
Excellent, thank you for that. I know there and apologies. I know there was a question about rates. I'm not sure if this is the appropriate time or place to talk about it. I know there was more information in the general core presentation as well. So I don't know if Katie, you have anything else to add to that? Specifically about if CPST does provide psychiatry or anything else, I think there are specific guidelines around that.
I'm sorry, I missed the very beginning. Are we talking about billing for it?
Yeah, the rates, really, yeah, reimbursement rates.
Yeah, so with CPST, there's actually multiple rate codes that are based on who the practitioner is. So there's one that's billed by MDs, and then there's a second one that I believe is physicians, assistants, nurse practitioners, and psychologists. Then there's another one that's nurses, social workers, mental health counselors, etc. So you're just going to want to look at the practitioner type on the rate code to determine what the billing amount is, but there is a higher rate to support the medical staff.
Excellent, thank you for that. All right, I'm just seeing if we missed any. So please feel free to chat in questions as they come up. Just looking to see if we have others that we have not addressed.
Looks like there is one around certified peers and CPST, and I do want to clarify that if someone's highest credential is that they are a certified peer, then they would not be qualified to deliver community psychiatric support and treatment. It is intended to be delivered by licensed staff, and I believe the only exception to that is a CRC, which is a certified rehabilitation counselor, and that's a master's level rehab counselor. Other than that, these services are provided by licensed staff only.
Yeah, thank you for that. But clearly, just like in PSR, and as you talked about, peers could work closely with CPST providers, providing peer services and so forth. I know there's also a question around, and I think in your example, you actually touched on it with PSR and CPST as an example, kind of delineation of services and who provides what. I don't know if you want to touch on that again. I know there was a question about, kind of multidisciplinary team approach. And I think, again, this goes just be, not only about CPST, but I think CORE allows for people to really do that approach, right? But clearly making sure that everybody knows their role and what they're delivering. So I don't know if Katie or others, you want to add anything to that.
Yeah. Well, so with any Medicaid service, we're always paying attention to duplication of services. That is something that we want to avoid. One of the things that I love about CORE services is that we allowed for billing for talking to other service providers. If the individual identifies them as someone who's important in their recovery, so they are identified as a collateral, then you can call them up and talk about what it is that you're doing with the person and share service plans, and that work is billable. So we really want to see that coordination, integration, collaboration. If you're working for a single agency, that's always nice because you can have those clinical treatment team meetings. Hopefully the person would be invited and included in that process. And in many cases, you're going to be kind of standalone, and maybe someone is going to a primary care doctor at another agency, and they're receiving health home care management at a third agency. We would still love to see as much integration and coordination as possible. CPST clinicians are not meant to be case managers, so while they might facilitate a referral here and there in the same way that an outpatient clinic therapist might do so, they should always be giving the health home care manager a heads up if that care manager is, if the individual has a care manager. I think that communication is really just going to be the key to preventing any duplication of services. And then providers will just need to have a very thorough understanding of the service definitions and components to make sure that they understand where CPST ends and where PSR begins. And if anyone wants to discuss specific components or specific questions, you can always reach out to our mailbox and we will try to clarify that for you.
Excellent, thank you. I don't see any other questions that came through. I'm not sure if there's any other areas or that you would like to comment on or mention as we see if there's any additional.
Yeah, I'm just scrolling through the questions. I think we really have covered all of them. But if there are additional questions, I would just encourage you can always reach my team at adult-BH HCBS@omh.ny.gov, and the OASAS team can be reached at PICM@oasas.ny.gov.
Excellent. Thank you. I think with that, we'll conclude today's presentation. And again, thank you to our state partners for the presentation. Thank you for the panelists, for the participants joining us, and for all the questions. And look out for more information to come. All right, thank you, everybody, and have a great rest of your day.
Thank you.
Take care.